This program is brought to you by Emory University.
All right. Hi, good morning. It is my pleasure to introduce Dr. Kendra Grubb, who is an assistant professor in the Division of Surgery here. She's also the surgical director of the Structural Heart and Valve Center. She joined Emory last year, and before that, she was at University of Louisville, where she also directed the minimally invasive structural valve center there. And we're very excited that you're here. I think, like Bob said, it's a daylight savings time, and also it's the first of the month, so maybe the residents and the fellows are also changing and didn't show up yet, but they will. So, catheter-based valve therapies, a paradigm shift in the treatment of structural heart disease.
Wonderful. Thank you so much. Thank you for this opportunity to present today. I am representing the Structural Heart and Valve Center. I'm going to be talking about some of the updates in our program as well as some of the new technology. Here are my disclosures. So our objectives today, first, what is structural heart disease? There is sometimes confusion around that. I'm going to use aortic stenosis and the Tavor pathway as an example of how things have changed, and then talk about this new paradigm of patient-focused management of structural heart disease, focusing specifically on the lifetime management of these patients, and then also delve into a little bit of the new technology in this field. So let's get started. What is structural heart disease? Well, really, it is a defect or abnormality of the heart that is non-coronary. So valvular heart disease, atrial septal defects, ventricular septal defects, and even congenital abnormalities fall into this bucket, actually, of structural heart disease. And traditionally, these were managed by cardiac surgeons, and now oftentimes these diseases are being treated with transcatheter approaches. So when we talk about structural heart disease today, common things being common, we have atrial and ventricular septal defects, aortic stenosis, now treated by transcatheter aortic valve therapies, mitral regurgitation, both degenerative and functional, being treated with clips or replacement valves. There are about 60 different mitral devices being developed now, all trying to figure out how to treat mitral regurgitation with the various etiologies. Tricuspid regurgitation is kind of the final frontier. In surgery, it had been kind of the forgotten valve, but now, again, we have multiple therapies addressing these very sick patients who suffer with tricuspid regurgitation. And finally, what can we do for heart failure? And that's going to be, I think, a topic of the future, is how these various valvular pathologies are presented as heart failure, and really should we be addressing this at a ventricular level as opposed to a valvular level? And this being one example. So let's talk about aortic stenosis and how we even got to the point that structural heart disease became really a transcatheter therapy. So we know that there's a high prevalence of aortic stenosis, 16.5 million people in the US over the age of 65. And we know that the definition was updated in 2014 with the guidelines, with the aortic valve area less than 1 centimeter, and the traditional high gradient severe aortic stenosis being defined by a jet velocity greater than 4 meters per second or a mean gradient greater than 40. We then have these other entities with paradoxical low flow, low gradient, or just low flow, low gradient, where the ejection fraction is less than 50%, where the ventricle can no longer generate those velocities or gradients. However, the valve area meets criteria, and with a dobutamine challenge, oftentimes we are able to reproduce true aortic stenosis. So we see that these patients are going to present with dyspnea, decreased exercise tolerance, heart failure, angina, syncope, or pre-syncope. But to keep it simple, this is a heavily calcified valve and a patient who usually can't catch their breath. And we know that these patients' life expectancy is truncated, and if they present with heart failure, we know that 50% of these patients will have died within 2 years. We also know from studies in cardiac surgery that early and late outcomes were similarly good in both symptomatic and asymptomatic patients treated surgically for severe aortic stenosis. And so we know that the therapy improves their survival. We know that without therapy, the likelihood of surviving beyond 2 years is less than 50%. But we also know that less than 50% of patients are actually referred. So aortic stenosis or severe aortic stenosis is underdiagnosed and undertreated. It used to be that the treatment options were really open heart surgery or transcatheter valve therapies for those patients who were too sick for open heart surgery. And that started in 2002 with the first in-man transcatheter aortic valve. The trials started in 2007. And if I have only open heart surgery to offer a patient, I have some limitations. Here is depicted a traditional open heart surgery, median sternotomy with mechanical valve, with the downstream effect that, yes, I've given them a valve that will last forever, however, they will be on Coumadin the rest of their life. And what is the repercussion for having Coumadin in an 80 or 90-year-old? So for patients who initially were deemed high risk or inoperable, we had transcatheter therapies with various approaches to place an aortic valve within their existing stenosed valve. Just as a summary of the landmark trials, you can see that this started in 2002, as mentioned, with the very first in man with Grubb, with the partner trial starting, the results of the partner trial presented in 2010, going from high risk and inoperable to intermediate risk, and then most recently, low risk being presented at ACC this past year. We've had these therapies around for a little short of a decade now. We know that for high risk and inoperable, the first two commercially available valves were approved in 2011 and 12 and then 14. What's happened since then? The delivery systems have gotten smaller, more flexible. We're onto the third and in some cases the fourth generation of these devices. And with smaller delivery systems, we saw fewer vascular complications and more patients being able to be treated by a transfemoral approach, which has shown a survival advantage as well as less complications. We also saw a decrease in mortality, a decrease in stroke, and in 2016, finally saw intermediate risk approval. Now, risk at this time was based on your risk of dying from an open heart surgery, which we will revisit because that may be a constraint that is inappropriate in today's management of valvular heart disease. But this really started a paradigm shift in the management of patients with aortic stenosis, with smaller delivery systems, with valves that were repositionable, with the ability to precisely place valves exactly where we wanted to place them. It was only a matter of time before we knew that we were going to see these valves being used in younger patients and lower risk patients. So now we have the newest generation of this valve with the lowest profile, the smallest delivery system. It's repositionable, and it's addressed many of the problems that we saw in the early Tavor valves: paravalvular leak, pacemaker, and stroke, mortality, all decreasing. But until recently, everything we knew about transcatheter valves, everything was based on studies in octogenarians. High risk, inoperable, intermediate risk, everything we knew was based on randomized controlled trials of 80-year-olds. More recently, we've had some insight into how these valves perform in lower risk patients. In 2018 at ACC, NOTION, the Nordic Aortic Valve Intervention Trial, presented 5-year outcomes with all comers. These were patients who were treated with CoreValve Classic, the first generation Medtronic valve. And what they found was excellent results when compared to surgery in regard to mortality, stroke, and myocardial infarction. For patients with a Society of Thoracic Surgery risk score of less than 4%, they showed equivalence of surgery and Tavor for this early experience with the first generation valve. This was subsequently followed up by the Tavor low-risk patient trial, where 200 patients were compared to 719 surgical patients, which were weight adjusted at 11 centers. At 30 days, 0 all-cause mortality in the Tavor group versus 1.7 in the Tavor group, 0 strokes. At 1 year, again, no durability issues with patients who were low risk. In March of this year at ACC, we finally saw the results of the 2 low-risk trials. Both Edwards' partner trial and Medtronic's low-risk trial were presented back to back. This represented over 2,400 low-risk patients treated in both surgical arms and the Tavor arms. To keep in mind what these patients look like, we still aren't talking low-risk 50-year-olds. The average age in the Partner trial was 73 years. However, what they found was excellent results with superiority of Tavor to surgery in terms of their primary endpoints of all-cause mortality, stroke, and rehospitalization. Of their secondary endpoints, again, superiority for, non-inferiority or superiority for Tavor, with the exception of new permanent pacemakers being 6.5. They did show more patient prosthesis mismatch, the other PPM, in the Partner trial. At the conclusion of the presentation, it was the presenter, Dr. Marty Leon's, statement that Tavor should be considered the preferred therapy in low surgical risk patients with aortic stenosis. And I want to pause here to think about this information. I just told you that the average age was still in the 70s, and many low-risk patients are going to be far younger than this. For me, I'm not ready to give up on surgery for low-risk patients because what this trial also showed is that this low-risk patients did very well. And so the other thing that we have to keep in mind is that this is only 1-year data, and these low-risk patients have many, many years to live, and 1-year data, in my mind, is not quite enough for me to completely give up my surgical practice. Another very important point that is hidden in the back of this publication is that 35% of the patients in this trial were excluded. We don't know who they are, and we don't know what this means. And over 50% of the patients in this trial had some form of patient prosthesis mismatch in the Tavor arm, small valves being put in large patients. And what is going to be the downstream effect of these as we go forward in time with these patients with small valves? These patients are followed for 10 years, and so we will know the answer. But today, I don't feel that we have the data necessary for me to reliably say this is the preferred therapy for patients with severe aortic stenosis. So we must pause and think about the data that's being presented to us. In terms of Medtronic's trial, this trial similarly looked at low-risk patients, an STS risk of 3 or lower. 3 different generations of valves were included. 99% were done transfemorally. Again, the average age, 74 years. However, they did show non-inferiority to surgical aortic valve replacement, meeting all endpoints for mortality, stroke, and they did, however, find a 17.4% pacemaker rate, which again causes me to pause in low-risk patients. This high number of pacemakers has been challenged, and they are doing a follow-up study to this, specifically looking at newer techniques of implantation in order to try to mitigate this high pacemaker rate. But again, if your patients are 65 years old, does a pacemaker at 65 cause you to pause? Now, the Tavor arm wasn't without pacemakers, but it was significantly lower. Just to reiterate, death, disabling stroke, heart failure at 1 year, the composite rates showing non-inferiority for Tavor, with excellent results in terms of patient prosthesis mismatch. The core valve is a supraannular valve, known to have a larger EOA for the same size annulus. The conclusion at the end of this presentation was that Tavor may be a preferred strategy to surgery in patients with severe aortic stenosis at low risk of surgical mortality. And certainly at this point, I believe this to be an accurate statement. We have 4 low-risk trials, all pointing to excellent results for the Tavor valves at out to potentially 5 years. There is also a meta-analysis specifically looking at 7 trials of 8,000 patients who are assigned to Tavor versus Tavor, with all-cause mortality lower in the Tavor group, 12% relative risk reduction up to 2 years, and even lower, 17% relative risk reduction if they were performed via the transfemoral approach. Clear benefits in terms of stroke, 19% relative risk reduction, and in conjunction with the mortality benefit, certainly evidence to suggest that we should be discussing both options with every patient. Now, to take a little bit of a detour, I mentioned before, is it appropriate to be using surgical risk to decide who should or should not be getting a transcatheter valve? Here you see the distribution of aortic stenosis patients demonstrated in a latte. And we know that this is based on an actuary, right? So how many patients have had a surgical aortic valve replacement that are placed in the STS data pool, and then I can query that data pool using my individual patient's demographics, past medical history, et cetera, and come up with a risk. But does this really have anything to do with their risk of Tavor? And I think that at this point, it doesn't necessarily equate. We know that the guidelines actually show that it doesn't matter who you're talking about other than prohibitive risk patients. Surgical aortic valve replacement is still a class 1 indication for high risk, intermediate, and low risk patients. The guidelines have not changed yet. Tavor should be considered in any patient with severe symptomatic aortic stenosis other than those at prohibitive risk. And this leads us to this paradigm shift. We now have enough data, over a decade of data, so that we can have meaningful conversations with our patients. As a surgeon, I should be doing my due diligence and letting the patient know what to expect from surgery or from transcatheter valves or from medical therapy, depending on the patient. And so it's time that we start asking, what do low-risk aortic stenosis patients really want? If you're low risk, does it make sense for you to go to surgery because you're going to have 30 years to live? Or does the first platform being a transcatheter valve make the most sense? I don't have the data today to answer that question, but I think it's an important conversation that we should be having with our patients. So when we ask low-risk patients what do they want, the primary focus is to fix the problem. Fix the valve effectively with the lowest risk of death or complication and the least disruption of normal life. As those familiar with the Emory program are aware, our patients are now done under conscious sedation, just like they're getting a PCI, and they typically go home the very next day. I can't offer that from a surgical patient. They're going to spend 4 days in the hospital. They're going to have 6 to 8 weeks of downtime. So we're not necessarily offering equivalent experiences when you're talking about disruption of normal life. But we do have secondary considerations when we're talking about low-risk patients. They want a valve that's durable. Will this valve last? They want to have good functional status, low risk of stroke, low risk of pacemaker. What about coronary access, and what about valve and valve suitability going further? So what do low-risk patients really want? Well, the low-risk patient has changed significantly. Patients being considered for Tavor versus Tavor have changed dramatically. 75-year-olds can be very active now. And what do they really want? They want to move like Jagger. And believe me, we have patients come to clinic who ask for the Mick Jagger procedure. He was the best advertising for Tavor they could ever have had. So we need to change the conversation to look from low risk, high risk, intermediate risk, to this concept of Tavor suitability. Concept of surgical risk is outdated. It only looks at STS predictive risk of mortality for surgical risk, and it really doesn't serve our patient population anymore. We should be considering Tavor suitability. What specific things about that patient lead to favoring surgery versus catheter-based therapies? What is the optimal treatment strategy for that particular patient? And what is the lifetime management going to look like? The choices I make today, and we're going to revisit this, the choice I make today is going to influence what I can do in 10 years, 15 years, 20 years, because many of these low-risk patients are going to live that long. We also have to keep in mind, who were those patients excluded? We don't have the exact numbers of who fell into these categories, but having participated in these trials, we know that some of these patients had a heavy calcium burden that extended into the LVOT, and they were excluded. We know that some of the patients had true bicuspid valves or dilated ascending aortas. And the bicuspid registries will help answer some of the bicuspid questions, but certainly a patient with a 5.3 centimeter ascending aorta should be considered for surgery at the time of their bicuspid valve replacement. There were patients with low coronaries, and there were patients with other types of root abnormalities that really would benefit most from traditional cardiac surgery. And so when we release transcatheter aortic valve replacement on the general population, we have to keep this in mind. These people were not studied. So What if we talk about treatment based on age, suitability of the therapy? Because if you are 90, you probably are only going to need one valve. And so I am okay with calling 90-year-olds high risk, 80-year-olds intermediate to high risk, 70-year-olds low to intermediate risk, and 60-year-olds, this slide needs to be updated because that trial is now completed, shared decision making. So if you are 90 and high risk, it makes sense to have a Tavor valve. If you're 80, a 10-year valve will likely be all you need. We are approaching some of the 10-year data with the early experience with Tavor, and so I'm okay with saying an 80-year-old should have a Tavor valve. If you're 70, what is the likelihood that you will require a valve-in-valve? What other features of your past medical history are going to make a 10-year valve good enough for you? And if I decide to do a Tavor valve and I expect you to live to 90, I want to start with the largest platform available, the largest EOA, and a valve that I can build another valve in. And 60-year-old, I still think you're kicking the can. You have to worry about the 2 PPMs, patient prosthetic mismatch versus permanent pacemaker. What about coronary access, and what about durability? Again, to reiterate this discussion about PPM, and the permanent pacemaker arm for core valve, a rate of 17.4% to me is not acceptable. But this is something that I think can be overcome with technique. Patient prosthetic mismatch is literally the size of the valve, and so you're stuck with whatever frame you start with. And this is something that is not able to overcome with time. And in fact, as you put more valves inside, you just keep getting smaller. So these all have to be taken into consideration when we're talking about what valve to place in a patient. But these same considerations we have to think about for our surgical valves. If I get a preoperative CT on a small lady and my surgical valve is going to be small, I may think that in that particular patient, a Tavor valve is the first choice, may be the right answer if she's young. But we have to take each patient individually. I will say that if you start with a patient in their 60s or younger at the time of their initial valve, I do believe that you will need a sternotomy somewhere in their lifetime. And so planning that lifetime management of valvular heart disease becomes much more important. So I'm going to show you a little bit of an example. As we talk about the evolution of Tavor, the question of which comes first. Can you do a Tavor and a Savor? Can you do a Tavor and a Tavor? We don't know that answer of the TAV and TAV. And what about a third valve? Are you going to be able to do a TAV and TAV and TAV? We tell the patients we can, but we don't know the answer if you start when you're 60. I do believe that there will be new devices to address these specific challenges, but we don't have them now. TAV and TAV and TAV, are you planning your first sternotomy at 80? Is it going to require a root replacement or an ascending replacement, trying to get all these valves out of the root? We don't know, but we can certainly guess that we may be creating a new type of surgery, just like the congenital surgeons 20 years created adult congenital, because those kids now live to be adults. We may be creating a whole new form of surgery of what to do with 3 Tavor valves that are then incorporated into the aorta. So when we talk about lifetime management of valvular heart disease, here's a great example. This was an initial surgical valve, a 21 millimeter mitral flow. The inner diameter is 17, which is very small. This patient's valve failed in less than 7 years. A 23 millimeter evolute was placed inside, but the valve was placed extremely low. You can imagine all of the other things that it's interfering with. What about pacemaker? Certainly the membranous septum could be involved in this. What are the options later for the valve-in-valve that's going to happen the second go-round? What about the mitral? It's entirely possible but that valve is interfering with the anterior leaflet of the mitral valve. And would a transcatheter mitral valve even be feasible? And of course, what about the coronaries? In this particular instance, you can see the left main and access will be easy. But what if I put 2 more valves in there? What do I have now? So at this stage, with the information that we have, I do believe that low-risk patients with severe symptomatic aortic stenosis should get the choice to have Tavor. They should. They should have that choice available to them. But we should also remind them that Tavor is still the gold standard and has been for over 50 years, that the guidelines still have Class 1 indications for surgical aortic valve replacement for low, intermediate, and high risk, that the current long-term data is limited, and most of it that we know from approaching 10 years is in octogenarians. And although a 10-year valve is likely good enough if you're 80, it's probably not good enough if you're 65. The low-risk trial show excellent early results with one trial with durability out to 5 years. We have to be cognizant of the lifetime management of these valves, and it's very important to individualize these patients' care. So certainly the 2020 question mark update, I do expect Tavor to have Class 1 indications across the board, which then puts the onus on us to make sure that we're having an appropriate conversation with every patient that we counsel. So the future of structural heart and valve disease is focused on shared decision-making, making sure that the patient understands that the choice you make today is going to impact what we're able to do in the future. It relies on a collaborative multidisciplinary team with one surgeon and one interventional cardiologist based on the new NCD that was released this year. But it's a pathway. It's a streamlined patient pathway with lifetime management involved and lifetime follow-up of these patients. So what we've learned from Tavor can be extrapolated to the other types of structural heart disease, specifically other valves. So what is our next phase? Well, briefly, as we get into mitral valve disease, we know that there are, mitral valve regurgitation was the first pathology of the mitral valve to be addressed. For the medical students, mitral regurgitation is blood flowing backwards into the left atrium and pulmonary veins and results in impaired left ventricular function. We know that this disease process affects about 4 million people and with an incidence of 250,000, but only about 50,000 of these patients are treated surgically every year. Broadly speaking, there are two etiologies: degenerative, where it's a leaflet pathology; prolapse, flail, a chordal rupture or leaflet restriction; or functional, where the valve is normal, but the ventricle is enlarging, causing the regurgitation. The MitraClip was the first device to be FDA approved to treat this, first in degenerative and then more recently in functional mitral regurgitation, a clip that attaches the two leaflets together to reduce the regurgitation, and an edge-to-edge repair technique that results in tissue bridging with a double orifice mitral valve. The results were excellent in the functional group, showing decrease in mitral valve or mitral regurgitation severity, improvement in New York Heart Association class, and this led to a whole host of other devices trying to mimic the excellent results demonstrated with MitraClip, with other clip ideas, annuloplasties, etc., trying to address the various types of mitral regurgitation via repair technique. Not to be left behind, there were mitral replacement options, and currently there are multiple being investigated. Here's a demonstration of 4 of kind of the front runners in the United States, with D being Tendyne, which is we are currently enrolling in at Emory. Not to be forgotten, the tricuspid valve is another potential area of further investigation. It's the forgotten valve no more, and as there are many, many options for mitral interventions, now the tricuspid valve similarly with clips and annuloplasties and spacers and various ideas to try to decrease tricuspid regurgitation. You're also able to place a valve inside of a failed tricuspid repair, which we do frequently here at Emory, as well as in a failed replacement. So we have lots of options for transcatheter tricuspid therapies, many of which are being investigated. There is an international multi-center tri-valve registry trying to figure out which of these devices will be front runners. So far, there are many options, none of which are really leading. They're all very challenging to place, with patients who are able to be clipped really having the largest experience at this point. One of the areas of development here at Emory is a pledgeted assisted suture tricuspid annuloplasty, where literally we are sewing the leaflets together or sewing the ventricle together in order to try to reduce the regurgitation. This is something that we are investigating in collaboration with the NIH with some success. So that leads us to transcatheter heart valve devices. I mentioned earlier, many of these patients are presenting with heart failure. And so what if we addressed some of these pathologies as if they were heart failure patients, as opposed to patients just with valvular disease, and we went after the ventricle? So here's one example. So for example, here we talk about heart failure and this important treatment gap. We know that initially medical therapies are the first line of therapy, then you get into CRRT and ICDs, and then late you end up in the VAD transplant group. But in the middle is an unfortunate period where the patient continues to dwindle. Their life can be quite miserable. And so we're looking in that space to see if there is a therapy that we can implement in order to increase the amount of time before they need the VAD transplant, or if we're able to get this right, eliminate the need for the VAD or transplant totally. All of this is very early in the experience. One such device is called AccuCinch, and we are a team that's implanting them here at Emory. And this is a ventriculoplasty. The idea is access through the aortic valve, placing a wire below the mitral valve, behind the papillary muscles and chordae, placing anchors into the posterior ventricular wall and literally pulling that portion of the wall in to realign the papillary muscles and regain the conical shape of the ventricle. Here you can see an example of with the anchors placed and then with the tension, the reduction. And here you can see that it's flexible, and this is one of the patients that we were able to help here at Emory. So this is a left ventricular repair of systolic heart failure. It reduces LV volume and dimensions, reduction in afterload, hopefully making the pump more efficient and improving the ejection fraction, reduced LV wall tension and stress, and in certain patients, reducing mitral regurgitation as it reshapes the mitral apparatus to improve geometry and reduce tenting, a reduction in preload, and it doesn't preclude other therapies. The nice part about this is you could always go back and touch up the mitral leaflets with a MitraClip, and if the patient did end up down the VAD pathway, it does not interfere. So just to give an example of one of the patients treated here, 47-year-old gentleman, a BMI of 28. You can see his past medical history, a dilated cardiomyopathy presenting with class 3 heart failure. He had had an ICD placed. His ejection fraction was approximately 27% with 2+ MR after medical optimization. And we were able to place a cinch with 30% reduction, 30% diameter reduction and LV reduction of 9.4 millimeters. At baseline in 30 days, here you can see that his ejection fraction had increased from 15 to 20% to 25 to 30% with a reduction in his mitral regurgitation as demonstrated here. Improved ejection fraction and reduced MR being our goal. We've seen him now at 6 months and he continues to improve. His ventricular size continues to remodel. Across the board for these trials, we are seeing consistent results with improvement in ejection fraction initially, and more importantly, the patients feel better. Quality of life scores improving and walk tests also improving. There are 3 arms to this trial, one specifically for functional mitral regurgitation, one for failed previous mitral interventions, and one for specifically heart failure. And we're hopeful that there will be more trials of this type with transcatheter therapies addressing the ventricular issues associated with valvular heart disease. And with that, I thank you for your time. I'll take any questions.
I'll start you out with one. So a lot of our decision-making of who eventually gets to you guys depends on symptoms. And if, if the Tavor study showing improvement or benefit of Tavor over surgery is better, there is a benefit of Tavor over surgery in the low-risk patients, do you think will ultimately redefine who comes your way?
I do. In fact, there is a Tavor that, or excuse me, there is a trial that we are participating in called Early Tavor, and it's specifically for those patients who have met the disease criteria based on their echo, but they are not symptomatic yet. So when we talked about the guidelines, those are all in symptomatic patients. And so what's happened is that patients have traditionally not been sent to us until they have symptoms, even if you're following severe aortic stenosis by definition on the echocardiogram. So one, we are studying this group of patients, 2 arms. Ultimately, everyone ends up with Tavor, but essentially you present with severe aortic stenosis but are asymptomatic. This has to be proven with a treadmill test. Immediate randomization, 1 arm gets Tavor, 1 arm watchful waiting until they become symptomatic. These patients are followed for 5 years. At the time that a patient becomes symptomatic, they flip over and they get Tavor. And we're going to learn about whether or not there is an advantage long-term for these patients who are treated even though they don't have symptoms. I do think that when our only option was open surgery, you have to make different decisions because of the risk of the operation itself. Now that we're into 3rd and in some cases 4th generation Tavor valves and really advanced delivery systems, the ease of the procedure, the fact that they come in, they get their valve, they go home the next day with very low risk of death, stroke, or MI, we're in a different phase, and I think you're going to be seeing that these patients benefit from earlier treatment, especially in our octogenarians and nonagenarians.
Ooh, okay. So we always have to say symptomatic or asymptomatic. In the asymptomatic group, when they come to the clinic, of course they have to undergo what I call an interrogation. Like, you have any shortness of breath? Nope. You have any chest discomfort? Nope. How do you feel climbing stairs? Well, I don't have any stairs. So sometimes it's revealing to put them on the treadmill. And the trial you're talking about, interestingly, we're using the modified Bruce protocol with the exercise test to see whether or not they can get in it. So many times you'll be surprised when you put them on the treadmill, just like put them on the treadmill with a regular Bruce protocol. And when they've not complained of anything, they've contracted their activity such that they don't have anything to complain about. Then when they go 3 minutes to say, I'm exhausted, then it gets them out of the asymptomatic category into the symptomatic category. So it takes all that to try to adjudicate symptomatic from asymptomatic.
I want to go back to the mitral side. So as you know, there's a spectrum of response to the mitral clip, which is what we have now for repair, non-invasive repair. And do you foresee going forward with all these devices that some approaches may be different? You got the big ventricle, small ventricle, and so forth, as to how you might select patients. And as you're entering trials with various things, how do you, who's going into these trials? Are these, for instance, trials with the annular reduction, are these patients who are more COAP type patients, or are they more mitral FR patients? What's in there?
So you bring up an excellent point, and the reason that I kind of just flew through mitral is that that could be a 4-hour presentation in and of itself. The reality is we don't know. I will say that mitral clip works very well for high-risk patients with degenerative mitral regurgitation. That's the perfect patient for a mitral clip. The COAPT trial looked at patients who did not necessarily have large ventricles. It was a very narrow window of patients, and the early results are very good, again, in high-risk patients. I don't think that you can use that data to extrapolate to very large ventricles, to low EFs, or to patients who could potentially be surgical candidates for other reasons. we don't know, and so you kind of ask a question, will there be different arms? Yes, I think that over the next 5+ years, we are going to learn which types of pathologies are best treated by an annuloplasty versus a clip versus ventriculoplasty versus a replacement. The hard part about functional mitral regurgitation is that there's not necessarily a surgical precedent. We've never proven as surgeons that patients get better because we replace or repair their functional mitral regurgitation. It's a ventricular problem. And so without that surgical precedent, what's happening now is even in the functional trials, they're going away from a surgical arm and they're starting to compare these patients to clips because of the COAPT data. So we're in a very interesting place in terms of how muddy the data is and what do we know, because there are so many presentations for mitral regurgitation. I think it's going to take us a much longer time to have a definitive answer when it comes to the treatment of mitral disease than it did for aortic. Aortic valve is a valve in a tube. It doesn't really do much other than turn a little bit and open and close. That's what it's supposed to do. The mitral valve, of course, as we know, not only is it attached to the ventricle by papillary muscles and chordae, the entire posterior wall moves with every heartbeat. And I think that when we thought that we were going to have quick solutions to all mitral regurgitation, I think we underestimated the complexity of the valve or the disease process. It's going to take us much longer to come up with solutions.
So thanks so much. I had two questions. One's a little bit in the weeds, and the other is maybe a little bigger picture. But the one in the weeds is, you mentioned at the end some of the benefits you're seeing in quality of life for the patients with the remodeling procedure. You know, one of the things that to me was really sort of puzzling about the COAPT data is the fact that you have improved quality of life and declined 6-minute walk. Right? So you have two measures, a sort of functional status measure that goes down, and this kind of patient-reported or patient-assessed outcome that gets better, which it's really hard to know what to do with that. So I'd be interested in your thoughts about sort of how we go about assessing and using quality of life data in these contexts. So that's the one that's in the weeds. The second one is more with regard to kind of a follow-up to Spencer's question, which is that, especially with all the kind of muddiness about COAPT, how do we think about sort of design of trials moving forward in terms of, does it need to be, do you try to pick people who are COAPT ineligible and focus on that population? Do you compare to the clip in COAPT eligible patients? Or how do we kind of move forward?
Well, it depends on who. I'm going to answer your questions actually backwards because you're right. The second one's a little bit easier. So I think that, as mentioned, now that you don't have a surgical precedent, and we know that goal-directed medical therapy in at least COAPT was inferior, now you have a metric. And so in terms of using that metric, the problem is always going to be that you didn't have the same population of patients that you had in COAPT. One of the things about COAPT, and we talk about it frequently in valve clinic, is that there were a tremendous number of patients who were excluded. What had to happen in COAPT is that you had to be on goal-directed medical therapy. And many patients, they got so much better with goal-directed medical therapy just because they were seeing a heart failure specialist and they were actually being treated and monitored that they never ended up in COAPT. And so we have this huge population of patients that were excluded but actually did very well. And we don't know anything about those guys. So I think that the COAPT data now stands as a very low bar because I think that all of these mitral devices appreciate that there are some limitations to that. And it's not going to take much in the functional arm of things to be able to have better results than better results than MitraClip for functional mitral regurgitation if you take all comers. Do I expect that you're going to have some exclusions? I do. So I think I took the slide out, but if you look at, if I would have left it in, you would see that even in the ventriculoplasty, they're not taking all comers for mitral regurgitation. You have to look at wall thickness, you have to look at scar, so you're excluding some of your ischemics that may be good candidates for MitraClip, COAPT, et cetera. So it gets very, very challenging. Your first question about quality of life. So that gets to what are we trying to achieve? Right now, I feel that we're in an era where CMS really wants our patients to feel better. They want us to pick patients and therapies so that patients feel better and they stay out of the hospital. And so quality of life metrics such as walk tests and KCCQ are outweighing whether or not your ventricle actually gets better because you feel better. And I think that's a hard endpoint for us, but I think that it's an important one. And certainly that's what CMS is looking for. No, that's true. That's absolutely true. And we talk about this. One of my disclosures was that I sit on the advisory board for Ancora. And we talk about their pivotal trial. We are trying to design the pivotal trial for mitral regurgitation for Ancora. And we go round and round about whether or not a sham is appropriate in advanced heart failure patients with mitral regurgitation and bad ventricles. Is a sham where you'd go to the operating room and put them under general anesthesia, is that appropriate? Or is it dangerous? And so we don't have the answer yet, but you're absolutely right. A sham would help us answer this question.
What's the current recommendation for antiplatelet therapy after Tavor? And then I've seen some folks, I sort of want to know, what's your threshold? I've seen some of my patients get converted to anticoagulation, like at their 30-day echo when the gradient's a little
Yes.
higher than you guys like, and we have presumptive then valve thrombosis.
Sure. I specifically didn't get into the HALT data. It was presented at TCT in September, that leaflet thickening. So Edwards presented their data at TCT. Medtronic won't present their low-risk HALT data until ACC. So I don't feel comfortable saying much because it may not be a class effect. What we have traditionally been doing, initially, everyone was on aspirin and Plavix. And that was, we didn't know what to do. It's kind of like a stent. We'll just put aspirin and Plavix. And that started for a year, and then it went 6 months. And none of the studies that have been done have ever proven that one strategy is better than the other. And so currently where we are right now at Emory is 162 of aspirin, 2 baby aspirins. I mean, it's got as much data as dual antiplatelet therapy. There are different teams across the country who do all kinds of different strategies, and none of them has proven superior at this time. We know from those studies, however, that using NOACs or Coumadin does increase the risk, and so that is not necessarily advised, unless, as you suggest, what we see at the 30-day echo is sometimes an increasing gradient. You, at that point, have 2 choices. Essentially, you can do a 4D CT and prove that there's no thrombus on the leaflets. But we have also seen that even with that, just putting a patient on full anticoagulation with Coumadin, that gradient goes away by itself. The 1-year data from PARTNER suggests that oftentimes the HALT, the leaflet thickening, does go away at 1 year. So we don't quite understand what the mechanism is. We certainly don't understand who should have what anticoagulation. So right now at Emory, we're choosing kind of the safest choice, and 2 baby aspirin is what we picked.
Yeah, I think one of the, just from a patient approach perspective, I've been impressed with the valve team, and that you are looking at what happens not just with the procedure, but what's going to happen over the following decades with the patient. And your consent forms are very detailed, much more than what we see for just informed consent for procedure. But my question would be, as you go through this experience, what's your perception of how we do informed consent for cath lab procedures, surgical procedures? Do you think what's going on within the structural valve arena is going to have an impact on what is eventually required for informed consent for, an abdominal surgery or whatever? So
I do. We didn't invent the multidisciplinary team. The oncologists and surgical oncologists have been doing disease-specific multidisciplinary teams for a very long time, and we followed their model. And so out of that comes the ability to take multiple different people's expertise and consent a patient with not the only option is surgery or the only option is this, but, and it's not the consent form itself, it's not the consent form for the actual abdominal operation. By that, I mean, the cat's out of the bag at that point. It's the conversation that got us to that point. And I think that's where the biggest change happens. I no longer see a patient and I'm telling them you have to have surgery for your severe aortic stenosis or your risk of dying at 2 years is 50%. I know that to be true, but I'm telling them you have choices. We can do nothing and this is what you can expect. You can have surgical aortic valve replacement and this is what you can expect. Or there's Tavor and this is what you can expect. Here's the limitations of each of those and helping them to try to choose what's best for them. So I think that conversation, it's the lead up to the actual consent, not the actual, that's not the piece of paper. The piece of paper is the legal document, but it's the conversation that leads us to that that's a really important piece. And so absolutely, I do think that you're going to see changes in that. I think it's important, you know, if you have complex coronary disease, the answer isn't always PCI. And you should be having this conversation about what would open heart surgery mean and what are the risks? What about PCI? What about medical therapy? And they should be having that. And I'm not sure that that's happening. So that happens way before the consent itself. It happens at the time of diagnosis of the disease. You know, it's challenging right now because we are being referred patients who, you know, if you tell a patient, oh, they're going to crack your chest, nobody wants that. Nobody, right? But it may be the right thing to do. And so I think that we have to make sure that the patient understands that, one, there's no cracking involved, but two, that because of these other things, like the slide I showed with the people who are excluded, because of these other things, the overall treatment may be better. And then, of course, the opposite. You know, if I have a 65-year-old patient who's adamant that they want a Tavor because they want to get back to life quicker and they understand the risks and they know that they're going to have another intervention in their lifetime, as long as they take responsibility for that, you know, and a sternotomy at 72, 75, our studies have shown they do very well. So I think we're at a really interesting time where it's not the consent itself, it's the shared decision making.
My question is related to the indications for pacemakers, and I wondered, one, is your only indication that of complete heart block, or the other clues that you use to say that we're going to do this? And secondly, is there a delayed response, that you have somebody come out of surgery good, and then at a month later you realize that they need a pacemaker?
So a very low percentage will have the delayed pacemaker, less than 1%. Probably about 1 in 1,000 if I think about the number of patients who have late heart block. What we mostly see is that the initial conduction disturbance goes away by their 6-month follow-up with EP. And so we're actually putting in a lot of unnecessary pacemakers, and we've kind of, there's a balance between trying to get patients discharged early versus watching them in the hospital and avoiding pacemakers. And we haven't made that avoidance of pacemaker a priority. And so many of those patients did not need a pacemaker if we would have waited and let their conduction system recover from the insult of either the valve or the balloon. There are specific trials that are going to be done nationally to start addressing this, to really define what you see as an initial conduction abnormality and what the management of that is. Oftentimes, complete heart block is a no-brainer for us, right? You put in a temp perm, you wait till the next day. If it's not better, they get a permanent pacemaker. And I continue to believe that's probably the safest approach for complete heart block. But what about that patient who comes in and ends up with a new right bundle, right? I mean, we're observing those patients now with some criteria worked out with EP, but we don't have necessarily defined pathways. And are we waiting long enough to see if they recover? We don't have the answer yet, but we're working on it.
Well, let me, we got 1 minute left. Let me ask you, I saw something in the email of a study, I think it was in JAMA, and it just came the last couple of days, challenging the follow-up. It was from probably UCSF, but Rita Redberg was involved in it. So, and it was something like both with Tavor and with MitraClip that the post-market surveillance is inadequate, and we're missing complications. And said, you know, the criticism said TVT is, you know, voluntary or whatever, and we're not seeing, and so we're not totally transparent about complications, including mortality, that may be related. Have you seen that paper?
I have not seen the paper, but I would agree with what you just stated. For MitraClip as well as for Tavor, there is a TVT registry, also backed by the STS, where we collect the data of these patients at 30 days and 1 year only. We don't have long-term data beyond that. And so I think that that longer-term data beyond 1 year, there's no requirement beyond 1 year, is important. We will be relying on the low-risk trials to get us that 10-year perspective, but certainly with what we're doing currently with only 1 year requirements, it's totally inadequate. But that's where we are right now. I think it made sense when you were talking about high-risk or inoperable patients, because what you were ultimately asking at that point when the registry came out was, did you select patients who were actually going to live a year? And in the beginning, some of the high-risk and inoperable patients, we didn't do a good job. And if you look at those results, the mortality at 1 year was excessive. But we're not in that era anymore, and the registries have not caught up. I think there's a need to follow these patients much longer. Thank you very much for your time today.
The preceding program is copyrighted by Emory University.